مؤنس أكاديمي. بسم الله الرحمن الرحيم. أقدم هذا العمل خالص لوجه الله الكريم، آمل أن يكون عونا لشباب الأطباء ليقدموا خدمة صحية عالية المستوى ترقى بمكانة الأطباء العرب وتخدم المجتمع بأمانة وإخلاص. Here is case of 57 years old woman with history of cholecystectomy, have a GERD and on BPI. He is hypertensive diabetic. Her bowel started change 6 years ago, ولكن last year after cholecystectomy he feels that the frequency of her stool is increased, and last 2 months I have 2 episodes of incontinence. He denies any blood in stool or nocturnal diarrhea. He feels that her life is changed after cholecystectomy because of the diarrhea is increased, and whatever she went, he looking for the bathroom around because she has the sudden urgent of defecation, and he denies fever, weight changes, and fatigue. So her medication is pantoprazole, lisoprazole, metformin. The last colonoscopy was 5 years ago prior, and she had no polyps. Boston bowel preparation score 9, and you perform an workup for C. diff and infectious etiology, which negative. So you decided to do colonoscopy. You do colonoscopy, and here is the figure. As you see that normal colonic mucosa. You take a random biopsy from the right colon, left colon, and terminal ileum, as well as transverse colon. The pathology saying that there is a dense infiltration of lymphocytes, 33%. That means that more than 20% of lymphocytes in the superficial epithelial cells, and the crypt is preserved. So what you will treat this patient? You will give her a bismuth subsalicylate or budesonide, or you ask the patient to stop metformin or stop pantoprazole, or you will give her a 5-amino salicylic acid. Right. The treatment is budesonide. Why? I diagnose this patient as lymphocytic colitis. Lymphocytic colitis, one of the types of the microscopic colitis. Microscopic colitis is the 2 types, either lymphocytic colitis or collagenous colitis. Lymphocytic colitis is dense infiltration of lymphocytes in the subepithelial space, more than 20%, while collagenous colitis, thick band of collagen. Which type of collagen? Type 1 and type 2 in the subepithelial space. So what is the causes of microscopic colitis? BBI, selective serotonin reactive inhibitor, antibiotics, and smoking. What is AGA, American Gastrointestinal Association treatment guideline for diagnosis and management of microscopic colitis? 3 potential initial therapies. Start by budesonide, bismuth subsalicylate, or 5-amino salicylic acid. التلاتة كانوا موجودين في الاختيار، ولكن الجايد لاين saying you have to start by budesonide 8 milligram for 8 weeks If didn't respond, you can give bismuth sulfate or 5-amino salicylic acid. If didn't respond for this, you can proceed for tumor necrosis factor alpha as a treatment. ولكن في 2017 الامريكان جورنال of gastroenterology clinical and systemic review recommend you have to treat according to guidelines, according to the severity. If it is mild, so you give lopramide. If it is moderate, give bismuth. If it is severe, give budesonide. Here is 2 choices for your treatment. You can start, my recommendation is to start with Imodium. Then if didn't accept, or you can add bismuth sulfate, or you can shift to budesonide according to the severity of the case. ولكن لازم نخلي بالنا من حاجة مهمة جدا. Before you initiate treatment, don't forget the cause. What is the cause? Is, as we see, chronic use of proton pump inhibitors. So I recommend for this patient to stop the proton pump pantoprazole, which is associated with microscopic colitis. After 2 weeks, when she come back after stopping BPI and improved, so no need to proceed for Imodium or bismuth salicylates or even budesonide. First, you have to stop the medication and seeing the patient respond. Here is a patient, 56 years old woman with history of clinical chronic obstructive pulmonary disease, presented to the emergency department with onset of abdominal pain. 24-hour earlier, he reported that his pain was 6/10. Crampy, diffuse through the abdomen. At admission, the patient's serology assessment was remarkable for white blood cells 16,000. 6 hours after the onset of abdominal pain, she experienced multiple episodes of bleeding per rectum. He described 6 bowel movements with bowel and clot mixed with a stool. She also denied contact, ingestion of prepared food, or any medication. You ask for CT. The CT shows segment colitis involving the descending colon at the rate as moderate to severe. The patient admitted, but her diarrhea continued over subsequent 24 hours and less blood than previously, but with similar frequency. He gave persistent symptoms. You decided to perform a colonoscopy that reveals the following figure. As we see, a linear ulcer started in the rectosigmoid, spread and maximum in the splenic flexure. According to American College of Gastroenterology guidelines for the disease state, we recommend treatment for this patient after intravenous fluid and bed rest. So what you recommend for treatment? Is you only bed rest and intravenous fluid, or you add ciprofloxacin metronidazole, or you make a bowel rest, ciprofloxacin, metronidazole, and CT angio, or bed rest, ciprofloxacin, metronidazole, CT angio, and refer for intervention, intensive care unit, or best bowel rest and ciprofloxacin, metronidazole, and CT angio, and refer for ICU and surgical consultation. يبقى العيانة دي هتعملها بيت ريست وبس، ولا هتدي سيبرومترو، ولا هتعمل CT انجو، ولا تحجزها في ICU، ولا هتكونسلت السيرجري. My diagnosis. So the diagnosis is ischemic colitis. Ischemic colitis is occurring at ulceration maximum as water shedded region, which is a splenic, where the most least vascular area, and the treatment depend on the severity. Severity defined by chronic ischemia plus more than at least 3 of the following. يبقى لو في chronic ischemia زائد 1 يبقى mild، زائد حاجتين يبقى moderate، اكتر من 3 يبقى severe. ايه اللي بنحكم عليه الريسك فاكتور؟ male, gender, hypotension, tachycardia associated with rectal bleeding, hemoglobin less than 12, white blood cells more than 15, BUN more than 20, lactic dehydrogenase more 350, and sodium less than 135, and sure presence of ulcer on the colonoscopy. So this our patient is. So this patient have 2 of the criteria, so it is a moderate, indicated for intravenous fluid, bed rest, antimicrobial, metro, without ICU admission, without consultation for the surgery. ولكن CT angio يتعمل إذا لقيت isolated to the right colon, not the left colon. Surgery and ICU admitted only indicated in severe stage or severe cases, depending on the number of the risk factors. More than 3, it's severe. 2, moderate. 1, mild. If you have signs of peritoneal irritation, if you have colonoscopy found gangrenous area, if it is isolated to the right colon, if you found a portal vein gases أو peritonism linears, you have to refer for surgery and ICU. And here a picture for portal vein gases and pneumatosis linears. هنا في pneumatosis linears and here portal vein gases. Finally, the take-home message is: don't forget chronic ischemia, and usually in hypotensive and in ICU patient. Thank you.